Next, we're going to hear about the surgical management of melanoma, and I would like to welcome our next speaker, Dr. Erica Friedman, who is an assistant professor in the Department of Surgery at Perlmutter Cancer Center. So let's welcome Dr. Friedman.
Hi, good afternoon. Thank you guys so much for having me. As Rachel mentioned, my name is Erica Friedman. I'm a surgeon here at NYU, did all of my training here. I'm actually fellowship trained at Melanoma Institute, Australia, where we see a lot of skin cancer. So I'm really privileged to be here, and I hope you learned something. So I'm going to talk to you, give you a general overview of how you might come to see me, a surgical oncologist, what you should bring with you, how I might treat you, and kind of hint at the fact that not one single person treats melanoma, but it's really a team effort. So a suspicious skin lesion, as Dr. Hale mentioned, if you're suspicious, get it checked out. You don't need to be a trained medical professional to note some of the lesions that she had presented. If something is bleeding, itching, failing to heal, if you're worried or notice any change, please go see a professional and have it checked out. That person may do a biopsy. You get your biopsy results. This may be told to you by a slew of individuals. You may be given a little bit of information, a lot of information. You don't know what to do with this information. Who do you go see? We'll talk about that in a second, but your best bet is either to talk to your dermatologist, and they may refer you to a person like me, a surgical oncologist that treats these kinds of things. An informed patient is a better patient, but you can't learn everything overnight. We've all done extensive training for this, and while you may go to the internet, some of the content is good, some is bad, and some is outright dangerous. So please proceed with caution. So you may end up on my doorstep. Again, I'm a surgical oncologist. I am a fully trained general surgeon. Most surgical oncologists, we have additional fellowship training in surgical oncology. Mine is different. Mine is specifically in melanoma and other forms of melanoma skin cancers. The focus of my training was really an emphasis on the patient with cancer and understanding not only the management, but also the biology of the cancer. But again, I am not a dermatologist or a dermatologic surgeon. There is a difference. We have different responsibilities when it comes to melanoma patient, and I'm usually the first person or the first physician a patient may see when they are given a diagnosis of melanoma. So your biopsy comes with a pathology report. Please bring this to your appointment. It is oftentimes read by a dermatopathologist. That's important because a dermatopathologist is also a pathologist that has additional training in looking at skin. And some of these things can be nuanced and may be overrepresented by a pathologist that isn't as well trained. The pathologist report really helps me to determine how I'm going to treat you and looking at margins am I going to take? Am I going to perform a sentinel node biopsy? Both of which we will talk about more extensively. It will assist me in determining your prognosis, and a well-done biopsy plus a well-read biopsy means that I can accurately stage you and accurately treat you for your melanoma. This is an example of a pathology report from a patient of mine that you'll notice here. The first thing I've highlighted is the first thing I look at when I see a pathology report, and that's the thickness of your melanoma. Dr. Hale did mention this. We'll go into it into a little bit more depth. This patient actually had a pretty nasty melanoma, 24 millimeters thick. That's very thick. Usually we're looking on the order of less than a millimeter or around a millimeter or two. Shown here is really to demonstrate what I mean by thickness, and this is measured from the surface, a particular level in the surface of the skin, extending down into the base of the melanoma. It's highlighted really well here. This is a nodular melanoma where you can see these different types of purple cells compared to the pink. Here the melanoma cells are highlighted in brown with a special type of stain that some of the pathologists use. The next thing I look at is whether or not there was an ulceration. That's demonstrated here by whether or not there was a portion of the overlying skin that was missing. Ulceration tends to portend a worse prognosis, so ulcerated melanomas tend to behave a little bit worse. Next, I look at the mitotic rate. The way I like to describe this to my patients is what are the revolutions per minute, or how fast is this engine running? So if the revolutions per minute are low, if it's 0 or 1, this means the melanoma is a little bit more quiet, a little bit more well-behaved, but if this number is elevated, can be a little bit more aggressive. Lastly, there are other pictures of this puzzle that I look at, such as microsatellites, or where there are little foci of melanoma separate from the primary melanoma. Did it start to invade the little vessels around the melanoma in the skin, or did it invade the little nerves? And so once I have that information, I could really formulate a treatment plan for you. And so today I'm really going to focus on two of the three levels of melanoma care and assessment. I'm going to leave the third aspect to my colleague here. So I'm going to focus on the treatment of primary localized melanoma when it's just in the skin, and the management of regional melanoma when it's spread to the lymph nodes. So I'm going to start off by telling you that William Shakespeare kind of got it right when it comes to surgery. Sometimes less is more. We're really moving, in most of cancer actually, to a less is more approach to the surgical management. And we've learned lessons from the past, and we kind of don't need to do as much. And I'll tell you what I mean. So in speaking of the management of primary localized melanoma, our goals are really thus. We want to surgically eradicate all the tumor cells in that area. We want to do this in a way that minimizes the morbidity or the disfigurement to you and maximize your functionality by minimizing your impairment. And so what this comes down to is I'm going to widely excise this. And so we like to base our decisions, our practical management of things on randomized clinical trials when available. And many different countries actually over a number of years really looked at this question of how much is enough to take. So when I take out your melanoma, I know that I can't just take out your melanoma because there may be cells I can't see. So how wide of a margin do I need to take? And you can see here that there's been 5 randomized clinical trials looking at a variety of margins, 1 versus 3, 2 versus 4, 2 versus 5. And essentially this is where the less is more comes in. And generally speaking, we know that we don't need to take a big, huge, wide margin. 5 centimeters is no longer necessary. We can take a narrower margin, but we still need some margin. And so these are the current guidelines in our country, and these really do reflect international guidelines as well. When you have melanoma that's confined just to the surface of the skin, we need a very narrow margin, and the margin we need to take increases with increasing melanoma depth. So shown here is kind of how we would work out the actual margin in the operating room. If you look on the photo on your right, you see that the melanoma is marked out in the inner circle, and then we actually use a ruler and we measure out a circle to determine our margin. And this must have been a thicker melanoma because you're seeing that there's a 2 centimeter circumferential margin taken around the melanoma. Shown here is what you might see in the first panel here. In situ or on the body, the measurement that we take, this is the scar from the excision. We've measured out a margin. We've elongated the incision in an effort to close it. This is what it looks like when it comes out of the body and is sent down to the pathologist. And when you look at it under the microscope, the star denotes the actual scar. The pathologist will measure it from the end of the scar to the end of the specimen to know that we took enough. So reconstruction, once I make a hole in you, how do I fix it? Oftentimes, we can do this with a straight line closure. So the brown line would indicate my obligate or what is necessary to take out. When I elongate this in an effort to close it in a nice straight line, and that's shown in stages here. So we've taken out the skin down to the muscle to eradicate the melanoma from you. This is what it looks like when it's been removed, closing it slowly in a straight line. What happens if something's on your face or in a more cosmetically sensitive area? If we were to close this in a straight line, we may pull down the eye or pull over the nose, and that wouldn't look very nice for you and can actually cause impairment in your ability to blink. And so what's done is we take out what's necessary, then we have to work out how to close it. And what's shown here is called a cervical facial flap or a rotational flap, using the laxity in your face that we have on the sides to pull in tissue without disfiguring the eye or the nose. And lastly, this is this gentleman many months out post-operatively, and you could see that while he still has a scar, the contour of his face is preserved. Another example of a young woman who had a melanoma on her nose. It was removed with a margin. This is the specimen once it's been removed, and then a skin graft was placed. This is using skin from another area to resurface the original area. You can see once she's recovered that it's really minimally noticeable and that the contour of her nose has been preserved. So now that we've talked about the management of a local melanoma when it's just in the spot of your skin, our treatment is to excise it widely. Now we have to worry about what happens if it has spread, or how do we evaluate for spread to what's called the regional lymph nodes. And so what is a lymph node? Lymph nodes are scattered all throughout our body, and they really act as little filters. They're there to pick up debris, to recirculate fluid. They can sometimes get enlarged when we have infection because their job is to pick up the infected cells. But what they can also do is serve as they're oftentimes the first point of spread for the cells of cancer, and in our case, melanoma. So if the melanoma cells were to spread, the first point of spread would be the lymph nodes. And so lymph node surgery, a little historical background, palpable lymph nodes. So you can see this very thin gentleman with bulges under both of his arms. This treatment really has changed. If somebody presents to us with palpable lymph nodes and we know they're from melanoma, the treatment there is to remove all of the lymph nodes. This is therapeutic, meaning treating the cancer. However, in patients that, when we examine them, have no clinically apparent nodes, meaning I don't feel anything when I feel your armpit or your groin, the old way of doing this, or even as recently as the 1990s, if your melanoma was thick enough, we would just take out all of the nodes anyway, because we knew you were at an increased risk of having spread. And so we were just going to remove the lymph nodes to hope that we were completely treating you. And this is really I'm sorry, let me go back for 1 second. If you had a thinner melanoma, we would just observe you. However, only 20% of patients that had an elective lymph node dissection had melanoma in their lymph nodes. And a dissection is not without risk. Anytime we remove all of your lymph nodes, there's the risk of lymphedema, which is permanent swelling in your limb that may impact your life. There's nerves that live around the lymph nodes. We can damage those nerves. And you're also at increased risk for infection once you've had all your lymph nodes removed. So combining this, 80% of people were exposed to this risk, but none of the benefit. And so this is an example of a gentleman who was treated in Australia in the 1980s. He had a relatively thick melanoma on his sternum with his revolutions per minute were a little bit high, so he had some dividing cells there. And so what happened was, in the way that they treated this, was they not only excised the melanoma, but they excised the melanoma, electively excised all of the lymph nodes where they thought it would spread to, and all of the channels between the melanoma and the regional nodes. And so again, I did my training in Australia. People like this are walking around at the beach, that they've got these huge patches of skin grafts on them, because that's the way we thought that more was more, that we needed to do the best that we could do for you and remove every possible route of spread locally and regionally to treat the melanoma. However, in the 1990s, a doctor from California said, wait a second, I think we could do better. And so what Don Morton did was he proposed a low morbid, minimally invasive alternative to electively removing the nodes. And the premise here was that we know that melanoma will spread via these little lymphatic channels, the channels in the skin, to what's called a sentinel node, the first point of spread, before reaching the other lymph nodes. And so Dr. Morton and his colleagues, including doctors here at NYU, participated in this very large randomized clinical trial, again, evidence, this is scientific evidence, called the Multicenter Selective Lymphadenectomy Trial, looking at whether they randomized patients. So patients were randomly assigned to either observation, we were just watching them, or we were doing what's called a sentinel lymph node biopsy. And what we learned from that is that, sentinel lymph nodes, a positive sentinel lymph node was the most significant prognostic factor. So if you had a positive node, we knew you did worse. And again, only 20% of those patients who had a sentinel lymph node biopsy, all comers, had a positive node. So again, we knew that 80% of patients could be spared a bigger surgery. And generally speaking, it's believed that there is no survival advantage for all patients doing sentinel lymph node biopsies. This is a point that's a little bit contended and a little bit too in-depth for this discussion. But let me further define what a sentinel node is so you can understand. This is an illustration. This is your tumor. The sentinel node is the first point of spread. If it's not in this node, it cannot possibly be in these other nodes. Here you see a tumor that has two channels leading away from it, so there would be two sentinel nodes. But again, if we inspect these, if we remove them and look at them under the microscope and the melanoma is not here, can't possibly be anywhere else. So how do we figure out what that node is? It can be quite complicated. If this melanoma is on your upper arm, typically it's a node in your armpit. If it's on your upper chest, it could spread in diverse directions to your neck or your armpit. And it becomes even more complicated if it's on your abdomen or your back, and it can go in either direction, to your armpit or to your groin. Sometimes if it's in the center of your back, it can go to all four basins, your armpits or your groins. So how do I figure out where to look? Essentially, this is called a sentinel lymph node biopsy, and it involves lymphatic mapping. So on the day of your surgery or the day prior to your surgery, you get an injection of a radioactive dye under your skin right at the location of the melanoma. You get a series of x-rays that pick up the spot of injection, that's this very dark mark, and you see that this dye travels the same way the melanoma would to the lymph node and accumulates there, allowing us to identify first where it is. Is it in the armpit? Is it in the neck? This is a superimposed image of that dynamic imaging we get onto the body, and you can see this patient had two discrete channels culminating in a single node. So I know at the time of the operation, I'm looking for a single node. That node will be hot because I have a handheld probe that will allow me to pick up the radioactivity. And it will be blue because at the time of surgery, around your melanoma into the skin, I inject a blue dye that is also picked up by your lymph nodes. So this is an example of the probe that I use that can pick up that radioactivity. And here you see the identification of a blue node. So I know that I've gotten the right node and I'm looking in the right place. So who do I offer this procedure to? Essentially, I offer this procedure to anybody who has a 10% risk or greater of having melanoma in their lymph nodes. So 10% or greater risk of melanoma spread. So patients who have what we would define as thick melanomas, greater than 4 millimeters, have about a 35% chance of spread. I'd be offering it to them. Patients with an intermediate thickness melanoma, between 1 and 4 millimeters, about a 20% risk of spread. Again, I would offer it to them. Patients who have a melanoma greater than or equal to 0.8 millimeters, so in this range of 0.8 to 1 millimeters, it's a discussion. Our national guidelines suggest it. I don't know that I would do it for all comers, but this is why this becomes complicated and requires people who know what they're doing so that we can have an informed discussion about it. Or if you have a melanoma that's thin, so less than 0.8, but has some negative features, like if that top was missing, if it was ulcerated, or had an elevated number of cells that were dividing. So again, we've not changed management for palpable nodes, but for patients who have what we call a clinically negative nodes, I cannot feel them. If you're less than 0.8 millimeters, I'm still just going to observe you with examinations. But if you're greater than 0.8 millimeters, I'm going to likely offer you a sentinel lymph node biopsy. If it's negative, great. I'm going to keep watching you. But if it's positive, and shown here again, the brown cells are the melanoma cells, what we used to do is say, okay, well, you had a positive node. There's a chance that you can have more nodes positive. I'm going to now remove all of your lymph nodes. However, this has also changed in the last couple of years, right? Less is more. So they're taking my job away from me. There's sometimes less of a role for a surgeon here. And why I'm saying that is because there's recently been a study that showed that I could potentially actively surveil you. And what that means is I examine you every 4 months, and I also ultrasound the area where the lymph nodes came out of. And this is the results of the second multi-center lymphadenectomy trial that looked at patients who had that positive sentinel node. So now you have melanoma in your lymph node. I'm going to randomize you, the trial randomized them, so you were randomly assigned to either observation with ultrasound or removal of the rest of your lymph nodes. The melanoma-specific survival, so your risk of death from melanoma in both of those groups was the same. There was no difference. And all I'm doing with this graph here is showing you that the people that had their lymph nodes removed, those are illustrated in the blue line, versus those that kept the rest of their lymph nodes, the lines are superimposed, they're overlapping. There's no difference in survival. So does this mean that there are no more lymph node dissections? Well, again, clinically palpable nodes, we do have to remove those in patients who have negative nodes on examination, but when I remove one and look at it under the microscope, there's melanoma there, so those are your sentinel node positive patients. It's no longer standard of care to remove all of your lymph nodes. That is, if I can trust that we can get ultrasounds on you every 4 months. If you're moving away where there's no good sound ultrasound techs, or I can't watch you, then maybe we should consider removing the lymph nodes to be safe. We know that this is a safe alternative in people that have small amounts of melanoma in their lymph nodes. However, the verdict may still be out in patients that have multiple lymph nodes, sentinel nodes that are positive. So if I removed 2 or 3 nodes from you and they were all positive, it's going to be a tougher discussion, a tougher decision on what to do. And if you had a large amount of melanoma in your lymph node, your risk of having additional nodes with melanoma may be higher, and it may be worth removing them. But that's still a question that we have. So surgery for what I'm going to call metastatic melanoma. So this is when melanoma has spread either in the area of the melanoma, so local regionally, in the area of the melanoma or in your lymph nodes, but to a point that it's not easy for me to take out or not possible for me to take out. So that's if you have multiple nodules, let's say along your leg or your arm, or you have big bulky lymph nodes that I can't remove safely, or if your melanoma has spread to distant sites. Surgery may not be the answer for you, and my colleague Dr. Pavlik will talk to you about that, but that doesn't mean that I'm on the bench forever. It may mean that there's a new role for me as a surgeon, as kind of I'm on deck. So if somebody like Dr. Pavlik treats you, and you have spots of melanoma that are persistent, that maybe didn't go away, or spots that are growing, or the spot in your lymph nodes has shrunk down to a certain point and you have no melanoma anywhere else, now I'm up to bat again. It may be my turn. So with the introduction of successful immunotherapy and targeted therapies, it may increase the role of a surgeon in patients who previously were considered unresectable. So how do we follow you? Again, I imagine Dr. Pavlik will touch on this as well, but it's really multidisciplinary. You need to go back to see your dermatologist because they still need to check your skin. They help to check your skin for new melanomas. For those of you, or for people who are diagnosed with thin, good prognosis, early melanomas, your risk is really in getting another melanoma as opposed to that melanoma causing you problems. And so your dermatologist needs to keep a close eye on your skin. Myself and my surgical oncologist colleagues, we keep an eye on your skin and also your lymph nodes. We monitor for recurrence. And then had you been introduced to a medical oncologist, they help us keep watch over all of you. Again, that's really demonstrated here in this interlocking multidisciplinary care of multidisciplinary model of follow-up, that your dermatologist really is responsible for detection and biopsy. They help us to treat thin melanomas or in situ melanomas. Myself as the surgical oncologist in red here, I'm really responsible for thin melanomas, primary melanomas, or melanomas that have spread to the lymph nodes but can be removed. The medical oncologists are responsible for melanoma that has spread past the point of me being able to remove it. So, thank you.